Folks, I think I'm I feel like a kid in a candy store today because I have who I call the godfather of GI oncology, the one and only Dr. Tony Saab, who is joining the Healthcare Unfiltered. Tony, everybody who is listening or viewing this knows how busy you are. So I really appreciate you taking the time of being on my humble, modest Healthcare Unfiltered podcast.
Well, Fashadi, it's always a pleasure to be with you, and appreciate the kind introduction. I certainly enjoy being on this platform. I know you've done a lot of great work, so I'm glad to be discussing some of the work that is in some ways transforming or is about to change the way we think about treating a number of our GI cancers. GI cancers overall are about a little bit more than 20% of all cancers we treat. So we're talking about 1 in 5 patients. But this encompasses at least 9 different anatomic sites in some ways, as you break them down. But also we're seeing more and more breaking down those cancers in subgroups and targeting specific subsets. So it's a very exciting time, to be in GI oncology, and certainly the field is changing very, very rapidly.
So you're getting people specializing in right-sided colon cancer and others in left-sided colon cancer.
Yeah, even more so, and then you get the transverse. I'm leaving this to John Marshall.
But Tony, I mean, I was a fellow when I first attended the first ASCO GI meeting, and I honestly remember there was probably 300 people. It was in San Francisco at the time. I think maybe 2001 or 2. I don't remember exactly. And there were like thousands of people now, abstracts, all of this, and you've witnessed that growth because you've been doing GI oncology for 2 decades right now. So it's pretty overwhelming when you go to these meetings. How do you even how do you even navigate these meetings to decide what are these clinically relevant abstracts that might have an impact on clinical practice?
Yeah, no, I think it's very challenging. So historically, so I have not missed a single ASCO GI since inception. I was one of the first and continue. I think I haven't missed a single one since, even during the COVID years. But I mean, the complexity of the field in gastrointestinal cancers is, as you described it, it's becoming dizzying to the point where most folks have to pick their favorite day. Is it Thursday for GE, or is it Friday for HCC, pancreas and biliary, or is it Saturday for colorectal? And then even then, you get the colon and the rectal expert, and you get the liver and the biliary expert. Well, I mean, historically, though, I started my first job as a GI oncologist that just saw everything, and I did that extensively for 10 plus years as we were growing our section of GI oncology at Ohio State. And I was pretty comfortable with essentially managing and navigating the world of GI with all its complexities. So I say today I have a bit easier job than those who are very specific about the one disease they care for, which could be liver or colon, where I actually do take care of all these patients and continue to do so, and have been accustomed to running trials across all the spectrum of GI cancers, and quite involved with phase 1 as well. And so that gives me a bit more ease in navigating the complexities of ASCO GI. But I would still, frankly, rely quite a bit on a lot of my expert colleagues in terms of catching up on data I may have missed or unable to attend for a meeting or side meeting. So it's a very collegial group of folks. We all have our venues afterwards, where we meet, discuss the various studies of interest. As you can imagine, everyone has their opinion, but that's how we all learn. And so overall, I think, yes, it's becoming more complex. But frankly, at least from a personal standpoint, I can't see myself being detached from one or the other. I still love to cover the whole gamut
All
of
of the GI
oncology and
oncology.
care for
But
patients across the
I
spectrum.
I did ask you something that is not easy, which is we have to talk about, top 4 or 5 clinically relevant abstracts. And with the thousands of abstracts, I totally recognize it's really very difficult and challenging because sometimes the clinical relevance is in the eyes of the beholder. So there's no one better than you in just taking us through few abstracts that caught your eyes and said, you know what, this may have actually a clinical application tomorrow. So you pick and choose which one we should start with.
I mean, I think that instead of just, focusing on one abstract, that I'd like to actually go more, what diseases may or what anatomic areas afflicted with cancer would have essentially either studies that move the field or confirming areas of interest leading to the next step. One of the areas that's incredibly interesting and has seen a lot of development is liver cancer, HCC specifically, hepato-cellular carcinoma. I remember, and I always note that when I discuss with my fellows that when we started in GI oncology taking care of HCC patients, in fact, the medical oncologist was external to a lot of the discussions that happened in HCC. We weren't relevant. This was a disease that was mostly taken care of by hepatologists, surgeons. And if patients, were at the stage where they need to see us, we haven't had much to offer them. In fact, I remember that agents like Megace, even, capecitabine would be the ones we occasionally used. And sorafenib was the first win. Imagine that, today you say sorafenib, it's like saying a dirty word, for a lot of folks try to avoid this agent. But then it was, the only agent that actually had proven to have a positive benefit, at least in survival for patients, although it was incredibly rough, to use. And it took about another decade to get to the next agent in first line, lenvatinib. And then from there on, we started seeing all these, novel immune therapy agents making their way to HCC in the first line. And, we see responses now. We got accustomed to saying, well, you shouldn't expect a response. A stable disease is fine. Now we see responses. We even see complete responses. So we're moving the needle. We're talking about survival that jumped from 10 months to close to 2 years for many of these patients. We have other salvage therapies, et cetera. So the natural concept here that is an oncologic concept. If you start seeing activity in later lines of therapy, what do? You start moving it to earlier lines of therapy. So that's the natural progress of things. And so what I call this is, essentially, reverse migration of these active regimens into earlier lines of therapy. So the first thing we've heard about, and this wasn't at ASCO GI, but now a year-old study, but that's the first study that essentially showed any benefit in the adjuvant setting, and that's a study called IMbrave050 with atezolizumab and bevacizumab, which, as you know, is a first-line standard. So was looked at in patients with high-risk HCC. And in those patients, who had resection, received either atezolizumab, bevacizumab, or supportive care, or the just observation. The primary endpoint for the study was relapse-free survival, and it did favor atezolizumab, bevacizumab. We don't have survival data yet. We're waiting on that survival data. But that certainly was the first adjuvant study that met its primary endpoint in high-risk patients. So that was exciting because, we've been trying for the longest time, to move the needle there, and we haven't. And so, I feel that essentially is a move forward. Now, at at ASCO GI, we've seen some data from a study called RAISE in the adjuvant setting. The RAISE study essentially looked at patients receiving radiotherapy versus control. These were primary HCC patients who received radical resection, and they had to have the most narrow resection margin less or equal to 1 centimeter. So generous margin. No tumor found, of course, on scanning. But this study essentially with that met its primary endpoint. It did show that essentially the 2-year relapse-free survival radiation was better than the control group. Now, the problem is
interesting because radiation to the liver seems to be pretty rough to give radiation to the liver. So that's actually pretty good that we're able to deliver that.
Well, yes, but so there are limitations to this study. Well, one is that it was a phase 2 randomized control trial. The second is that essentially the standard arm at this point for adjuvant studies like this one, although a little different patient population, should have been atezo-bev. And the question is, whether radiation makes a bigger difference or not. I think it's reasonable. I think it just adds value. But I think it continues to tell the story of, yes, we can make a difference in earlier stages as oncologists, radiation oncologists, and others. But as oncologists, at least, now we're finding a bigger home for us in the earlier rather than the later. So we started with no home. Then we moved to, well, your home is mostly in the more advanced setting. Now our home is moving closer and closer to the earlier stages. And I'll tell you, it continues to expand. Another study that I think is relatively transformational, although again, we still need some additional data, was EMERALD-1. EMERALD-1 was a phase 3 randomized placebo-controlled study of TACE combined with durva with or without beva in patients with unresectable hepatocellular carcinoma that are eligible for TACE. Now, we'll talk about the end about one of the limitations here, or maybe we can talk about it quickly now. Is TACE is moving out as a preferred modality to be replaced by TARE.
So do you want to, for the non-GI oncologist, the difference between TACE and TACE is transhepatic
transarterial chemoembolization, and TARE is essentially radioembolization rather than chemoembolization. So rather than use chemo, you're using essentially beads. Y90, which at least in our experience and also in the experience of most folks across the US, is safer, a little easier on patients, and so it has become favored. One can argue back and forth, but that's not a point for argument. It's the point that will be made at the end is whether this is the study that actually is moving our standard at this point. Well, so let's go through it first.
Right.
So this study essentially had the complex design. It was a randomization 1:1:1, and so patients essentially would be either randomized to A, B, or C. And with arm A and arm B, patients would receive durva and TACE. Arm C, they would receive placebo plus TACE, placebo for durva. And then after that, patients would receive durva plus beva or durva plus placebo for beva or placebo.
That is complex.
It is complex. But the primary endpoint was progression-free survival, looking specifically at arm B versus arm C, meaning durva TACE followed by durva beva versus placebo plus TACE followed by placebo. So it was powered, a little bit more simplistically. Anyways,
so that was the question, trying to understand how much durva would add to TACE conceptually. Is that what the question was?
No, it's actually more also the contribution of beva plus durva versus placebos. So it's an overall regimen rather than just just the durva plus TACE, because it looks at the whole at the whole continuum of treatment instead. And so the combination therapy begins after the final TACE procedure.
Right.
And that's, that's part of the measure. So this was a large study, relatively well balanced, and the study actually met its primary endpoint. So progression-free survival for durva-beva plus TACE was superior to placebos plus TACE.
Mm-hmm.
And at the median, the PFS was 15 months for the durva-beva versus 8.2 months for the placebos. So almost double, not double, but almost double. The hazard ratio was 0.77. I mean, similar to what you see with IMbrave050, is there's widening of those curves and then there's collapse.
Mm-hmm.
Collapse, after a while, meaning, most patients will progress. And so the question, of course, similar to what we've seen with the adjuvant setting is, are these modalities that we're adding to local procedures just improving PFS without improving OS? We don't have the OS data here, same as we've seen with atezo-bev data in the adjuvant setting. So I think we need to have the survival data to understand whether moving some of these immunotherapy agents or immunotherapy strategies to earlier line of setting we're actually improving overall survival. We're improving biology.
Right.
We're changing the course, not just elevating a curve for a while and then not affecting the overall outcome. Because at the end of the day, these are not cheap regimens or agents, and we have to be very cognizant of the fact that unless we actually change outcome meaningfully, they may not have the role we think they do. I mean,
I also wonder that TACE, it seems like to me, this has to be done in a specialized center, right? Like, have you seen TACE being done easily at community sites, or this is very highly academic procedure?
I think overall HCC should be treated at in a more experienced site, and that's true for some of the cancers we treat, not all of them necessarily, but some of them, and this HCC is definitely one of them. Where it is very important to actually have a specialized team. Yes, TACE can be done in large community centers. It can be done, in a very small shop. Large community centers, they've done it successfully. They do tear as well. But the problem is this is a very complex disease, and we're not talking about just having the oncologist or the surgeon or the interventional radiologist. I mean, you really have to have everyone around the patient, that includes complexities of other meanings. But I want to also go back to a point. So that's not just the point. Transplant is becoming a bit more accessible to a lot of these patients, and the reason for this is because we've become a little bit less stringent about what defines a transplantable patient or a patient who is a candidate for transplant. And that becomes very important because a lot of these modalities that induce high responses, not necessarily, so the measure here would be more response and progression-free survival, not as much survival, which would indicate that I'm getting a patient that is not eligible to transplant to now become eligible to transplant. And understanding that transplant may actually be the modifier here.
So almost
and
a
we're seeing more
bridge to transplant.
Well, not necessarily a bridge. I mean, you're treating those patients. You are treating those patients. A lot of patients that we never thought would be eligible for transplant are becoming eligible for transplant. But again, this is why it's so important to have a team surrounding these patients that does include transplant oncology, or a transplant center. Because a lot of these patients may actually not be assessed correctly when they have a really good response. The caveat, though, is these immune therapies and even bevacizumab, they have prolonged half-lives. They may affect adversely the viability of a transplant or the complication from surgery for beva. And so appropriate timelines are being established, and there are guidelines now that continue to be developed. There are guidelines that exist but continue to be developed about who are those patients who are most likely going to be ultimately candidates for transplant. So going back to, to EMERALD-1, I think, it brings a very interesting answer to a question that we failed to produce with single agent TKIs at the same level. So that tells us that IO, as we move IO to earlier lines of therapy, whether adjuvant or in the setting of TACE and perhaps TARE, actually ends up improving outcomes, at least primary measure outcomes, PFS or DFS, pending survival meaningfully. And so getting us closer again, like I say, that reverse migration, the oncologist now is involved at every level of the care of the patients. And I think we're getting even close to the point where we're managing patients who are transplanted or potentially transplantable. And I think it's an amazing time actually to be in GI oncology, specifically, taking care of those patients with HCC.
Before we move on to the next clinical data and so on, just one last question. Whenever you do the TACE and the TARE, Tony, I presume that there is like a criteria, right? Like, if you have like 2 lesions, 3 lesions versus 6 lesions and size and things like that, or you can actually, it doesn't matter.
At this point of time, again, we are shying away from very strict criteria to more loose criteria. That's why, again, you have to have that multidisciplinary team around you. There are specific criteria that just at least establish that base, but that base is only a base. You build on a base. So the base is there to tell us, this is where you want to start, or this is your first point of consideration, but that should not be limiting for patients. Now, of course, if you have extrahepatic disease, that's a different discussion.
Right.
If you have, involvement of major structures, that would not, be amenable to resection or to transplant, and then that's a completely different discussion. But for that beyond that, I think everything is fairly so even a patient that starts, let's say, with multiple lesions, that does not mean that that patient will never be transplantable. In fact, we're again stretching the definition, and not because we just can, because it's starting to make more and more sense. And some of the data that's coming out does suggest that if you have a solid response that gets you, to a comfort zone where this can be done, then you should consider doing it.
That's great. Let's move on to another one.
Yeah, so I think one of the other interesting, concepts that is important to discuss is the whole discussion surrounding microsatellite instability high or mismatch repair deficient metastatic colorectal cancer. As you know, we've had KEYNOTE-177 that established the superiority of pembrolizumab to chemotherapy and became a standard for our patients with metastatic colorectal cancer with MSI high in the first line setting. And looking at the long-term follow-up, we continue to see about 30 to 40% of the patients going beyond 4 and 5 years, essentially free of disease progression and still alive. And this is the maximum time to treat was exposing patients to 2 months of treatment, 2 years of treatment. Sorry. So we could make a claim that we're curing about 30 to 40% of patients with single agent pembrolizumab in metastatic colorectal cancer that are MSI high. Now, the next question had been, we've seen a lot of data from a study called CheckMate 142, CheckMate, and it was updated again at ASCO GI. I think it had about 141 updates. And so I'm looking forward to the 142nd update, and maybe they'll seal the deal. We won't see that study updated anymore. But the point on this is that, Nivo, when you add a CTLA-4 inhibitor to a PD-1 or PD-L1 inhibitor, in this case PD-1, nivolumab, you actually see some high response rates. Very promising. But the question, of course, is in addition to this being a very selected single-arm study, do we have any evidence that adding a CTLA-4 inhibitor, which does come with its own set of toxicities and cost, is that going to add value for patients with MSI high, disease that ultimately, are receiving the combination? So the good news is we do have a study that was presented, and I'd say partially, excuse me, partially at ASCO GI, not fully yet, and I'll tell you exactly, why it's not fully presented as of yet. But this study essentially looked at nivo-ipi, that's called CheckMate 8HW, looked at nivo-ipi, so essentially the combination of nivolumab plus ipilimumab, so the PD-1 plus CTLA-4, versus nivolumab. So single agent, separation of component, great idea, right? This is what we want, versus chemotherapy. But the data that was presented to us was only the nivo-ipi versus chemo.
Yeah, which is what you wanted is against the nivo.
I want to understand whether that CTLA-4 is adding any value, right? And I would have been incredibly surprised if nivo-ipi looked any worse than chemotherapy or not much better. Well, it did. I mean, it was a positive study, but that's expected. And to say that that's definitive would be an overstatement, because the data that actually we want to see is nivo-ipi versus nivo. I want to know whether adding that ipilimumab, which adds toxicities and adds cost, is actually superior to nivolumab alone. Now, it is important also to understand a few things about this study. So first of all, the study was positive for its primary endpoint of progression-free survival, which essentially did favor nivo-ipi. Now, the numbers look pretty solid. The median PFS was not reached yet versus 6 months for chemo, which underperforms a little bit what we would expect. And the hazard ratio was a very solid 0.21. So of course, if you want to look historically, you would say, wow, this is, eons better than what we would have expected with single agent pembrolizumab. But this is where we have to be very, very careful.
Right.
And the reason why we want to be very, very careful is two things. Well, one is you can't do cross-study comparisons. That's a big no.
It's not gonna give you much.
But there is another caveat. There's another caveat to the study. The unspoken truth here is the reported outcomes were only in those patients with centrally confirmed MSI high dMMR status. There's about 15% of patients who did not get centrally confirmed MSI MMR status. These patients were excluded from the analysis. All what I know, these patients could have been MSS or whatever.
Do we know why they were excluded?
Yeah, they were excluded because they didn't have centrally confirmed MSI high.
Interesting.
But that's consistent with the intent of the study. So I'm not saying that they played or fudged the numbers. No, they reported what they're supposed to report. It would have been nice actually to see, and I'll tell you what, it would have been nice, and I hope that in a future presentation, we'll see all the patients, regardless of central confirmation, presented, because KEYNOTE-177 actually did not require central confirmation. Okay? So when you start doing historical comparisons, you actually fall in a big trap of different studies, different design. You're going with this one, you're going with a significant, with a significant bias. So we always undermine the risk of, our perceived bias as investigators. If I want to believe that the best option for the patient is nivo-ipi, or a dual therapy versus single therapy, and you're not blinded, so there's no placebo, and there's no placebo here, then, I'm going to look at a scan, and if it's 19% versus 21%, guess where my bias is going to lead me?
That tells you why I don't like RECIST criteria right there.
I totally understand. I mean, it has an element that's not, that's not an element that that you can control for unless you're completely blinded, which is not the case. But I think now that's the negative. But on the positive side, the numbers look incredibly solid. So if these results hold true versus nivolumab, and this truly is superior to nivolumab, that's your standard. I mean, there's no question.
I presume they will update this, whether it's this ASCO or ASCO GI next year,
hope so.
right? I mean, I
hope so. I mean, so there are, and I hate doing speculations. And I just to be very clear, I don't know the data. I wasn't part of that study, so I'm only an observer on this one. But there are two things that can be happening here. Well, the good news is that it's very likely that nivolumab is also performing much better than chemotherapy.
Right.
That's why they weren't able to report, because they haven't reached the number of events, and that's my suspicion. They haven't reached the number of events that are necessary to report out on the single agent nivolumab. But the longer it goes, there is a possibility that means your nivo, ipi, and nivo are very close, very tight. So it depends on when that gets reported. We'll see. That can mean one thing or another. But at this point of time, all what I want to say is we cannot take the study and say, the numbers look better than KEYNOTE-177, therefore everyone should get nivo, ipi. No.
And I think that's really fair. I mean, what you're cautioning people is, guys, gals, you can't do cross-trial comparison.
No.
You're telling me you expected this to be superior to chemotherapy, nothing was earth-shattering there. And
numbers look solid. Numbers look solid, no doubt. But you also are picking those patients with centrally confirmed MSI high DMMR, and we don't have a good comparator historically to that. So we will have to wait.
Sometimes I wonder, why do they need central review for this? Because I don't think there's a lot of variation, frankly, amongst labs, local labs, or vendors when you come to look at MMR. I mean, it's just...
You'll be surprised.
Really?
Be surprised. Yeah. I mean, there's definitely discrepancies, and I mean, you would assume, and it's it's mostly...
No, I mean, if there is discrepancy, I can see the value, but just judging from what it is, it just seems to me it's either there or it's not. But
well,
okay,
I mean, again, they excluded 15 to 17% of the patients that could not be centrally confirmed, and the question is, what would that curve look like if you just included all patients, regardless of central confirmation? And and to give the presenters the benefit of the doubt, they went through the rapid abstract session, so they had only very limited number of slides they could present, so perhaps they couldn't just expand on this. Again, I'm not gonna prejudge any of this. All what I'm gonna say is, I'm looking forward, as we all are looking forward, to the nivo ipi versus nivo. I am hoping it looks much better, because you know what? That will give my patients a more solid option for their MSI high disease. But today, given the fact that ipi adds toxicity, without seeing that data, I'm very reluctant to make any switch.
Yeah. I mean, it's hard for me to move on to another abstract without asking I don't know if it's the elephant in the room question, but sometimes I wonder, when you look at these IO therapies, how much of it is a class effect versus the actual drug? Like, is Pembro versus Nivo? I mean, we're never gonna have a trial comparing this. I don't think there are resources to do this, but it makes me wonder, right? I mean, because we see that in other solid tumors, in lung cancer, for example, we've seen some differences between Nivo and Pembro, and some of this could be trial design and things of that nature. So for example, in lung cancer, Pembro is approved for adjuvant therapy in resected lung cancer, but it's not approved, but Nivo is not. But I think that's probably a longer conversation to have. But I do think about this when I look at these type of trials.
Yeah, no, I totally agree. And I think there may be some nuances between the two. I just don't know if these nuances are meaningful enough clinically. I wouldn't waste a study on them, frankly.
Agreed.
But you can never make assumptions. I mean, in history of drug development, you can never make assumptions. I mean, we make a lot of assumptions. Is liposomal irinotecan the same as irinotecan? Some people are very adamant that it is, and some people would tell you, no, it's not. Is nab-paclitaxel the same as paclitaxel? Again, you get folks, who get very, very passionate one way or the other. But, at least with nab-paclitaxel, actually, we do have some data in lung cancer, or breast cancer. I mean, I don't do these cancers, but that looks pretty similar in the sense. But then we go back to pancreas, and it is said that, there are differences in the stroma that may explain why it may work here better than in other places. I mean, who knows, right? Until you make that comparison, you're never going to be sure 100%. But you also have to always assess the value. I mean, we talk a lot about cost. We don't actually talk enough about value. I think the value is more important than just the cost. The value that you bring the patient is a much global measure than just the cost. You go say, well, this is, a more expensive, reformulation of this drug. Okay. But for me to use it, does it really bring the value?
Right.
And how do you measure that value? And how much do you spend, on trying to measure that value, whether it's private or public support for that spend?
Perfect. That's like a huge thing. I mean, there are ways. I think there are some economic formulas to do this, but we're not going to go there because I mean, I think it's a whole.
They definitely are.
It's a whole different podcast. Let's move on to another one.
All right. Well, let's the last area that I just want to touch upon, a little bit is this whole emerging area of molecular residual or minimal residual disease assessment. That's a very interesting area, for cancer overall. But in colorectal cancer, it's certainly quite well represented. So just as a reminder, molecular residual disease or minimal residual disease is essentially looking at circulating tumor DNA from cancer cells following essentially, say, resection, meaning you've removed all the visible tumor. You don't have any evidence of clinically detectable cancer, and yet you have the evidence that there is circulating tumor DNA. So DNA from the cancer circulating in the bloodstream or not, so positive or negative. And that's assessing minimal residual disease. What that does, theoretically, it may create a window of opportunity. The question is, what exactly is that window of opportunity and what does it open up for you? And the answer is we don't know. So, theoretically, you could say that if we do it right, we can take advantage of that window of opportunity to start, treatment at a time where the cancer is perhaps at a minimum. But does that eventually, translate truly at the cancer being at a minimum? And does that translate into any meaningful outcomes on the long term? We don't know. Do you intensify, your assessments, scanning, blood tests, etc.?
Right.
Again, we don't know. We tend to do it, but we don't know. Now, what do we know, right? So far, what do we know comes mostly from, from a number of observational studies. And one of them actually was presented at ASCO GI by Pashtun Kasi. It's this trial called BESPOKE, using essentially a tumor-informed platform. But before that, there was a large study, Circulate Japan, presented by Takayuki Yoshino's group. Essentially, that study has had 3 arms, probably the largest study in the universe. And I mean, when they, when that group does it, they do it better.
They do it right.
Just amazing group. But anyway, so they had the Vega trial, the Altair trial, which are for negative MRD, positive MRD, and then they had the Galaxy trial. The Galaxy study was essentially a very large observational study. It was published in Nature, and then Medicine, and then was presented with an update at ASCO GI. They had about 3,000 patients, and they included stage 1 to 4. And they continue to confirm the same trend we've seen, before this update, meaning that MRD status after surgery is strongly prognostic. It also, allows allows for patients, essentially for physicians in some ways, to help with the decision-making process. Again, these are not randomized decisions. These are individual decisions based on the study, whether they treat, not treat, etc. But the point of it is that what they've shown is very powerful in the sense that there could be, and I emphasize the could with a big underlining, because we're not sure until we see the prospective data, but there could be a predictive role in addition to the prognostic role. So that's in Japan. What do we have in the United States? That's where the BESPOKE study actually was presented at ASCO GI showed essentially it was a 133 site study, had stage 2 and 3 colon cancer. And what it showed, is very consistent in terms of results than what we've seen with GALAXY. That's good. Consistency is a good thing in large studies. And in this study, in addition, to a lot of the elements that were consistent, I want to emphasize two of them. And again, they're very similar to what we've seen with the GALAXY. And that's that ctDNA positivity. And I think that's an important one. During surveillance, will predict for inferior disease-free survival, regardless of adjuvant therapy. That's now consistent between GALAXY and BESPOKE, meaning that patients who are MRD negative, who receive adjuvant chemotherapy in the two separate groups, again, no randomization, investigators picking up, but it is pretty astounding to see in both studies that those patients do not seem, at least in the period of follow-up, to have much of a difference in their outcomes historically. So that's intriguing. That tells me perhaps, there is a predictive value, but like I said, big underline, I wouldn't use it for prediction at this point of time. I want to wait for more randomized studies, but I think the trends are definitely going in a good direction. Now, I will end this also with one discussion, because there was one study that was very confusing in terms of its results, and that's NRG GI 005, the COBRA study. Now, this study essentially was a cooperative group study. It was for resected stage 2A colon cancer, so low risk. And those patients were randomized to two arms. Arm one would be standard of care, meaning active surveillance, which is typically what we do for those patients. And arm two was essentially assay-directed. Now, they did use the first generation of a liquid-only platform. And so this was not tumor-informed, liquid only, but it was the first generation, probably less predictive, or has a lower predictive value. And if patients had ctDNA detected, they went on chemotherapy, either FOLFOX or CAPOX for 6 months. And then if not detected, then they go on active surveillance. And
this was a prospective, right?
Prospective, yes.
To me, as a non-GI oncologist, this is a perfect design.
It's a fantastic design, as long as you use the right platform to enter into the study.
Right. Okay.
Well, so here's the primary endpoint of the study, which is a very practical endpoint, was essentially ctDNA clearance. How quickly does ctDNA clear? As you would expect, ctDNA positive status was detected in very small percent of patients, about less than 6%. So of course that's a challenge. And then through the first analysis, 16 participants with ctDNA detected, and 7 on surveillance, 9 on chemotherapy. Actually, the surveillance group had a higher ctDNA clearance than the chemotherapy group, which is totally unexpected. So 43 versus 11%. And so this essentially led to essentially the exact test to be not rejected, and then the decision rule from the studies, was for early stopping due to futility. So that was a negative study. I wouldn't say negative.
Okay, you've got some patients who were observed, which is standard of care in this 2A disease, and others If they were MRD positive, they were getting Kpox or FOLFOX, and the MRD negative, they were observed.
Active surveillance.
Active
And then
surveillance.
the primary the endpoint that we're looking for is ctDNA clearance.
Got it.
And so patients that went on the surveillance arm, because their essentially ctDNA was negative, the first 7 participants, they actually had cleared the circulating tumor DNA faster than the chemotherapy subgroup.
Interesting. That is interesting.
So it is interesting. And so clearance of ctDNA at 6 months in those that were positive at baseline was observed in essentially, 3 out of 7 in arm 1 and 1 out of 9 with arm 2. And essentially that led to the decision for early stopping due to futility. And I think, the question is, at the end of the day, is this a difference in the platform? Is it because it was a tumor uninformed, a liquid only, although, one would argue that this was the first generation, doesn't have as good predictive value. I do think overall, though, today, that the tumor-informed assays probably remain in the sense as a prognostic tool. I'm not going to call it a predictive tool yet. It's a prognostic tool. They have more established clinical validity and utility until we see, better outcomes with the tumor uninformed or liquid-only tests, or the plasma-only, I should say, tests. They're a reasonable alternative if you don't have the tissue. But if there is if there is tissue, which most of these patients do, we rely more on the tumor-informed assays. There's another element also, if there is time urgency, and we want to include this in the decision-making process, we're having some issues with the timeliness of the tumor-informed assays, but I'm being told that these will improve with time.
This is really interesting. This study would throw things off a little bit, but to your point is well taken. It's possibly the assay. It's the other thing is, I mean, my view on MRD is the prognostic value of MRD is well established, frankly, across all tumors at this point. It's really about establishing whether it's treating MRD positive disease patients early on is going to add any value. And I imagine that your field is working very hard to establish that question at this point.
Yeah, I mean, I think that a lot of the data is converging in a good direction. A lot of it remains observational, except for a couple. I mean, we didn't talk about dynamic, and dynamic rectal is tough to interpret, so I'm not going to go through it. But overall, I think when you look at the totality of the data, there's definitely a prognostic role, and there are hints here and there that it may end up with a predictive role yet to be defined by prospective validation. Which hopefully will help us with de-escalation strategies, meaning that I really want to try to avoid, putting my patients through the toxicity of treatment if they really don't need it. We know we cure a large % of patients with surgery alone, and when they don't need to be exposed to chemotherapy. Today, we don't have a good tool to actually decide on who gets it and who doesn't.
Well said. I mean, unfortunately, adjuvant therapy by default, you're over-treating a lot of people to cure the minority. But Tony, this has been really amazing to be able to just go over this phenomenal data from ASCO GI, and we have to do the mandatory picture, of course, because that's how we do it here on the podcast, as you know. I mean, it's all about marketing. Anything else before I let you go to your busy schedule?
No, we're all good. Thank you, Shadi, for the opportunity. It's great to see you, and till next time.
Thank you. Thank you.
All right.